Hello, I'm Charlie Wells and welcome to Self Matters, the podcast where we interview the people shaping the future of mental health. This week, I'm really excited to introduce you all to Professor Andy McDonnell. Andy is the visiting professor of autism studies at Birmingham City University. He also happens to be a pretty awesome clinical psychologist and director of Studio 3, which I'm sure he'll tell us a little bit more about, and a self-proclaimed expert on low arousal approach to therapy and specifically neurodiversity and autism. So Andy, welcome so much to the podcast.
Welcome to.
We want to understand who is Andy and how did you become a clinical psychologist? Lots of people want to be clin psychs, right? Lots of people want to be systems thinkers in the mental health, and you've done it. So we would love to hear your story. Who is Andy and where did it start?
I wouldn't say I was an undergraduate who wanted to be a clinical psychologist from the outset. I met an awful lot of people when I was young who said they were going to be clinical psychologists. I just thought at the time, is that really for me? So I studied in the West Country in Plymouth at the time. I eventually qualified in clinical psychology at Birmingham University and got my PhD there as well. But no, it wasn't necessarily my first aspiration. It was curiosity that really got me into this idea of clinical psychology. It was aspirational. I grew up in the south of London in a disadvantaged area. I don't want to give any violins here or anything else. I studied psychology because you could get a BSc in it, and I wasn't very good at maths, if I'm being totally honest. The subject matter was intriguing, but the whole clinical psychology thing really emerged post my degree. I ended up doing better than I thought, and then realised, yeah, maybe I could do something like this. Maybe I could do something a little bit that made a difference. So that led me to, before my professional training, getting experience. As it was in the 80s, a long time ago, when I had hair and I was young and enthusiastic, it was very hard to get jobs, even as assistant psychologist then. It's actually easier now. I don't want to upset anyone who listens to this thinking it's difficult enough. So my first job I took in care, working in a specialist service for people with disabilities and what they called challenging behaviours. It was the new word at the time. And I had no idea what I was doing whatsoever. I was there as a care worker. I thought they'd employed me because I was God's gift to psychology, but they'd employed me because I was male and big, which was now, in hindsight and retrospect, quite offensive, really. And we did a lot of crazy behavioural things. At that period in my life, pre-training and for about a few years afterwards, I was a mad behaviourist. That's the only way to describe me. Read everything, read Skinner's books, read everything, wanted to simplify the world, was passionate about it. But then over time, I started doing these things in practice and saw there's more to this than just one way up a mountain, and this is quite a limited approach. So what really happened was, working in practice there, we were doing things around behaviour that involved using aversives. I remember squirting lemon juice in someone's mouth to stop them regurgitating. And the early signs were there of the emerging Andy McDonnell, because I turned around to my supervisor and refused to do it the second time and said, I'm not doing this again. This is immoral. It kind of traumatised me a little bit. And then I went to work in an institution for people with disabilities, which was a contrast again, because it was a project where we weren't really welcomed by most of the staff that were there. It was really basic institutionalisation practice. And from then I got on to Birmingham University's clinical psychology programme. I couldn't believe I got on the programme, to be honest. I decided, though, I would try different things. So I got experiences in family systems work. I've got experiences of different kinds of approaches, even CBT, other areas. But when I finished, I still didn't know what I wanted to do. I went on a training course called Managing Violence and Aggression in a place called Monial Hospital for People with Disabilities. I can even tell you the date. It was in 1987. And the training course consisted of two instructors, in inverted commas, elderly men. One was ex-military, showing us a few techniques and tricks about how to deal with violence. And I was a trainee psychologist, so I was very well behaved for 2 days, Charlie. I didn't say a word. I waited for everyone to leave, and then I asked them the purpose of the training. What have we just done for the last 2 days? I got told by my psychology boss, a guy called Alan Richards, you've been given the remit to revamp the training for the hospital. So I got into this area, and then actually when I qualified, I just thought, well, actually, the people with disabilities that I work with, and then emergingly autism and neurodiversity, you can't get more disadvantaged in society than that group of people. I drifted back into that work. Within 2 years of qualifying, I kind of rejected being a radical behaviourist completely.
There are so many things that we're exposed to as part of our career in trying to build a care system. And there are obviously so many preconceptions about the way things have been done and always been done. And I think everyone out there probably agrees that we haven't treated sort of mental health in the best way throughout the history of time. In fact, we've been pretty appalling as a species to those people who are different or, I guess, slightly scary to mainstream society. But obviously, there was something about you that didn't feel that comfortable from early on. Has there always been an inner rebel in Andy?
I was, in the early days at school, quite quiet-ish, but I still had a rebel side of me. So it got me into trouble, not with teachers. I actually was exposed to quite a lot of violence when I was a youngster in school and in those environments, bullied. So I decided to learn martial arts to fight back. Not a good solution to anyone listening to this. You do it to feel safe and to say no one's pushing me around. And the danger is then you can turn into a monster yourself if you're not careful. The victim becomes the perpetrator, which I didn't, and I'm confident of that. So that was a driver that I wasn't really aware was in me as well. So when I saw people, as I saw it, being abused, I just connected with the fact of, I'm going to speak truth here, and I'm going to work with families, I'm going to work with individuals in practice. I'm not just going to give them a bit of paper as a psychologist that somebody will never read or some guidance. I'm going to work with real life people. So it kind of emerged over the time. I wouldn't say there was a coherent plan. And the reason for that was, I suppose it is being fiery. When we're working in this area, to me, it's a passion. To give you an example, I'm 62 now. People say things like, when are you going to retire? And my honest answer is, why would I retire from something that I love? I might do it less while I've got my health, while I've still got my passion about things, I'm still going to do it. And I suppose for me, my career has had a number of areas that have intertwined. I would advise certain entities about undercover documentaries, and it culminated for me with the horrendous Winterbourne View documentary, and actually deciding that sometimes people need to be called out. Now, also, people need to be called out for good practice. It's really interesting in positive psychological thinking that we don't think about that enough. You don't learn just from tragedy and bad practice. You learn from improving it and where people are getting it right. And I think that's the problem we've got. I think that's a fundamental problem we've got with our mental health systems around the world. I mean, I'm privileged to work around the world, not just in the UK. I see some mental health systems with more money, more resources. Some people who get some things better than us, some things less good. But the reality is, at the end of it, we kind of bumble along stigmatizing people with labels that are growing by the day. If you're the kind of practitioner who religiously believes that the diagnostic and statistical manuals, every contract in there is real, then you're delusional. If you equally say, well, in ICD 11, 12, we have these classifications. We live in a world where even money follows a label that you get. It's crazy. I'm sorry, I can't give you therapy because you're not labelled as having 7 different disorders. And disorders is a term.
We should be seeing each other as individuals, right? Personalised treatment plans. But the problem is you need a label to get a study. You need a label to get funding to do research. You need a label to get a nice guideline, right? The whole system of experimentation and signing off an approval requires a pathway. And you can't have a pathway for one person. You have to have a pathway for a group of people. And so those group of people need a label. And so we've built the system to serve the system rather than the individual. You have a really interesting blend of experiences, having seen the mental health system as well as the mental health patient at the same time. So many clinicians I speak to in their early careers become very focused on treating an individual, but you seem to have the ability to kind of look around and go, well, actually, the way we're doing this care system around it is probably neither helping, but actually might be making the whole situation worse. And then you obviously went into the documentary. So I guess, how did you start thinking about abuse in care systems and how that could be called out and how we should change that?
It goes pre the documentary as well. I had a placement in family therapy, a place called the Charles Burns Clinic in Birmingham. It got me to think about systemic working. You're dealing with a whole family unit. And then the work I was doing, for example, with disabilities, I would do my individual work, but then I would go and try and work on the ground to be authentic. I was involved, I won't go into too much detail, with some whistleblowing in the very early days of my career. Sometimes by just saying to people pre-whistleblowing, why are you doing that? Gentle challenging of staff who sometimes weren't aware that what they were doing was slightly wrong or slightly controlling in people's lives. And that became a driver for me. And so when we got to things such as Winterbourne View, the documentary, I thought a long time about whether I would do it or not. I didn't know at the time where the place was. I was told it was an undercover team doing some work in the service of people with disabilities. It's an autism, it's meant to be specialist. It is an expose documentary, and I would be asked to comment to what they found. Also at the time, There was an amazing individual who sadly passed away now called Professor Jim Mansell, who in learning disabilities in the UK was the guru as far as I was concerned. He was the man. So when I found out he was going to be the other presenter, that was okay with me. I suppose when you look at a system like that, it's a really good example. You see frontline staff systematically, not all of them, but many of them, abusing people like something out of a Milgram experiment from the 70s. I kid you not. I struggle to completely empathise with a system that also allows that to happen. So you end up with this two-tier bit. And the two-tier bit was people have enough self-awareness to know what's right and wrong most of the time. They don't need to go on a training course on learning right or wrong. If you think about all the abuse inquiries we've had over the years, that could have been one of the mad outcomes. Everyone's going to go on an NHS training programme on right and wrong. It'd be daft. The vast majority of stressed, poorly paid staff in care don't abuse people systematically. We don't give enough credit for the fact that when Winterbourne View, the documentary, came out and there was a bit of a storm about it, one of the criticisms was, well, the BBC shouldn't have done it because it was undercover and that's unethical. And one of the other criticisms was, well, what about the fact that staff are poorly paid and that's why they do this? That absolutely enraged me because that's just an excuse. Thinking systemically and thinking about the individual, I've always found it hard to separate them completely. Even if I was doing one-to-one, I couldn't help thinking, I've seen this person for an hour. That's an hour in their week, in their life. They need to get their lives built, not just the therapy in 1 hour. We can get it right for people's mental health systems as well. You can have the world's greatest therapist, but if you're still going back into a depressed, socio-isolated building with no friends, no connection, no network, you're probably going to be a little less depressed from therapy, but you're still going to be depressed.
The therapist can give you knowledge and advice, but you're going to have to take that and apply it to your life in order to actually feel better. And actually, that's the hard bit, right? No one gets better sitting in a therapy room. You get better learning something and applying it, which means changing things and trying things. Your big thing now is you're doing the low arousal system in autism. For those people who are less familiar with it, could you unpack what you mean by a low arousal system?
The low arousal approach to manage behaviour actually started in the intellectual disabilities area first, then autism. The idea behind it was to teach people some effective de-escalation skills. That's where it started. How can I keep someone calm and regulated in a situation? You do that by regulating yourself first. One of the cornerstones when I started writing about the approach is I didn't invent mindfulness, I didn't invent being regulated. But the idea caught on in the 90s to say low arousal approaches to managing behaviour means you've got somebody who's distressed and traumatised for lots of reasons. They're escalating in their behaviours. In those moments, rather than ignore it, how can I engage with that person in a safe way? So that then evolved into, how do I speak to people? How do you calm someone? Well, the key thing that came out of it for me was reducing demands in a crisis was our mantra. Getting people to give people space, less is more. Teaching people how to not restrain people, which is difficult. Don't go laying hands to people first. Give people space, keep people safe and calm, get people out of the way. Everything is about reducing arousal and stress in the moment. That's the mantra. But there was a set of principles behind it which grew bigger than crisis management, which was about don't re-traumatise the traumatised, is one of the mantras today. Reduce the stress for all of us. Stress is transactional in nature. Whereas things like anxiety is something we place in the person too much. You've got a particular label, you're obsessive. You might say someone's socially anxious. So the idea was, I started realising that from a clinical point of view, low arousal was about stress management and good stress management for people, to simplify it. So merging that together, we've got this crisis management program that's gone worldwide. It's in about 16 countries now. In certain countries, it's quite interesting that our same training, say, for example, in Denmark and Sweden, is done across a lot of different sectors. And it's essentially the same training. In this country, it tends to focus mostly on disabilities, children's services, autism, and some mental health. It does seem to vary by country quite a lot. Not the actual training itself, but culturally, what people think they should do around this area. So the ideas behind it were really about non-confrontation, gentle teaching, I would have called it in the early days, Quakerism, pacifism, even Buddhism. The philosophy was very simple. You don't do unto others in those situations. But it kind of cascaded out to this blurring of boundaries now to how do I work therapeutically with people?
The ability to learn is so affected by your arousal state, right? It's very difficult to learn if you're in a high stress state, but it's also very difficult to learn unless you're willing to have peaks of arousal where you learn something in it. So if we see a therapy session as effectively a high impact learning moment where we want people to learn stuff and understand it and apply it to their lives and internalize it, how do you think we should use low arousal approach to prepare people for therapy sessions? How could we make therapy more effective by getting people into a learning mind state before they start their sessions?
I believe that if we're thinking about stress traumatized people, even psychologically damaged, I hate that word, but that's what we're talking about, the therapy environment needs to be meeting people on their terms. So, for example, a simple thing, I know we have the horrible clinic model where we're expecting stressed people to travel for hours to see us for 55 minutes or an hour and a half, and then distressed autism, particularly neurodiverse individuals, travel home. So I think one of the first things about that is to take out that stress. So for me, I tend to focus first on the environment. I will see an awful lot of people in their own homes or out in safe open spaces, not for my safety, but because it takes us out of that therapy context. I will still see some people, this room I'm in here now, has sofas for that individual work if we need to do that. So the first thing is about how we apply that regulating ourselves, which is a cornerstone of therapy, and what is the message we're conveying to people to say, this is a safe place to be. So I quite radically believe that, for example, the online that happened of therapies in lockdown is something that we should have learned from. I had a guy with autism who said to me, an adult, I don't want to go back to going to an office, because he described his experience of travelling an hour and a half to get 10 sessions of what he was called cognitive therapy from sounding like a good therapist, of which at an hour pretty much rigidly it finished, and then he had the 2 hours to travel back, and he couldn't even process. He was so stressed about the process of accessing therapy. So I think that for me, a low arousal approach says you start with that. You start actually saying environmentally, systemically, there are more than one ways for us to engage with people as psychologists, as clinicians, as therapists. And maybe we should be changing our rule book a little bit more with this. I'm not saying that everyone can do this. Yeah, I'm quite comfortable working in different contexts. Some people are only comfortable working in therapy contexts in that room one-to-one, and I respect that. But I think if we were talking about this, even things like online engagement, we shouldn't be seeing it as something we did because of the pandemic. We should be saying this is a great opportunity for some, not all people, to access our work and how we work. So when I was trained in therapies, you regulate yourself first. You role model being regulated to regulate and help others. That's 2/3 of an interaction. I've met some amazing therapists in my time who, within 5 minutes of meeting them, you feel safe. They've barely spoken a word. It's in their non-verbal communication, which is a powerful part of low arousal. It's not in what they say with words. It's how they set the space, even how they sit. These are things we know in therapy, but I think one of the fundamentals is about the fact of our context. The other thing is, and this is my niche area, therapists have to also feel safe. Now, there's been an awful lot of stuff in the NHS over the years about protocols, almost like we're weaponising people with mental health issues, that this person who's coming through my door is going to attack me. Now, that can happen, but it's quite rare. The vast majority of verbal aggression leads to nothing. Think about it in your own day-to-day lives. You have a row with someone, that's verbal aggression. But those rows rarely lead to physical violence. Unfortunately, most physical violence is usually preceded by verbal aggression. So we build in this fallacy that if this person shouts at me, then they're going to hit me. Whereas from my therapeutic training, if they're going to shout at me, that's better than them incubating and having some cathartic release and frustration. I see therapy as having its place, but in the context of people's lives, we also need to think bigger than that. Yeah. Sometimes people's therapists are their friends, their family. If you look at the search, for example, on victim support that I've done a lot of work with around PTSD, often the best therapists are the people who are trained, recovering soldiers, people who've been through therapy themselves. It doesn't mean to say they're the only people. We were debating recently about the number of neurodiverse therapists there are. It shouldn't be that that's not possible. It's about that authenticity that comes with it, and it starts with the basics for me.
Really interesting points, and there's two that I really would love to pull out a bit deeper. You talked about online, and obviously at Hello Self, we run a huge amount of online therapy. And it is interesting that the number one kind of concern and question we get from our therapists is like, how do you help me manage risk remotely? Even though risk is, as you said, a tiny, tiny proportion of stuff that happens online, but it's the thing that worries them the most. So much can be done to build a low arousal space with body language, with your movement, with your tone of voice, with the way you interact and move around a space. It's much harder to do that on a screen. So have you got any tips for our listeners about how do you project low arousal through a video call?
One of the interesting things, my basic rules are you treat a video call like someone is physically present. Don't use all this symbols on Zoom or Teams with hand holding and symbols that come up on the screen. Don't do it. Start with having imagine and visualize that person's next to you. Now, I've got a little trick that I have as a treat. I use this connection I'm on now sometimes when I'm connecting with people online, and there's a reason for it. I'm lucky to have an office that's got a 5 foot by 3 foot projector. It projects a screen that large. So if I put this on what I call therapy mode on a wider screen, if I'm talking to someone on this system, they will see my entire body with a good camera. They will not just see my head in a screen. I know it's a very literal thing, but it's a very obvious thing. They'll be able to see my body language on the screen. Now, respectfully, they may not want me to see theirs. I see somebody at the moment who doesn't want to have their video camera switched on when they're speaking to me. I accept that. I hope we'll move beyond that at some point. So these are the kind of what I might call basic kind of tricks with it. Having a conversation like the person's there, reminding people that they can terminate that call. It's quite hard to walk out of the therapy space. It's very easy to switch one of these things off. So that's challenging for a therapist, but at the same time, it also gives a sense of control to the individual in that engagement. Generally speaking, it's about being authentic and removing the barrier that you can't do therapy online. Almost a lot of people are conditioned to think that it has to be in a room with your chairs at a 45-degree angle. That has its place, but it's almost become a religious movement. Somebody asked me recently, why are therapy sessions only an hour long traditionally? Well, it goes back to the old days, and it goes back to even further, of the magic 1 hour scheduling. It became almost a dogma that you could have 1 hour a week. You didn't have 2 or 3. What about the person who needs intensive therapy? What do you mean? You get an hour every Monday and it's always at 5 and it keeps me safe and my boundaries clear. Hang on, but some people would benefit more if they're making progress in therapy by having more sessions, and some people, it's too fast for them, the pace. That's some of my kind of tricks to train. To me, I think it is an opportunity. That man or woman who's neurodiverse, who's frightened of getting out of their own house, you can reach them in their house that you would never reach that person in your therapy space because they won't come. They'll be too overwhelmed to come.
No, I think it's great. Very briefly, let's touch on therapists. Obviously, therapists are experts at doing one session, then being able to cognitively switch to the next session, like a completely different case. But I've seen some really interesting data that shows that actually the effectiveness of a therapy session is as correlated with the stress level of the therapist going into the session as it is the member going into the session. How could we reduce therapist stress in the system, especially in a world now where people are packing in more and more sessions? This long waiting list of people are trying to see as many people as they can. On a video call, it can be literally as simple as hanging up and someone else is waiting in the waiting room. Therapists are brilliant at this, but have you got any suggestions on how they can reset?
I think we're brilliant at it in theory. There's a difference between the principles and theory and the practice. Yeah, I'm excellent at giving people stress management advice, I've been told. I'm not good at taking it myself still. I'll still be here drinking my cups of coffee, telling people that booze is not a good stress management tool. Just come back from a cruise. I don't drink very often. And I actually left the cruise thinking I should have said no to that drinks package. I always love the work of Peter Fonagy. I always quote it about the most important therapy outcome variable in therapy is the relationship between the therapist and the client, not the therapy per se, whether it's cognitive therapy, psychotherapy. And I think sometimes what people need to understand is there is, particularly in the NHS now, not so much in the private sector as well, where you are on that treadmill. And I think sometimes people are not necessarily being honest with themselves. If you actually say, who have I got the best emotional connections with? How effective am I? One of my favourite topics is tell me about a client, a patient that you really don't want to work with. Someone you just can't connect with. We need to get better at stress management in general. And I'm not just saying mindfulness, I mean a lot of stress management tools. I give a survey out when I'm working with families, therapists, professionals, individuals, and it has 9 to 10 of the most common evidence-based stress reducing strategies for people in general. Exercise is in there. Diet, God help us, is in there. Sleep. If you ask people to then talk about mindfulness, yoga, meditation is a big one. If you really ask people honestly, what do they routinely practice? For general staff that I work with, less than 10% of people that I work with can come up with any strategies at all that they routinely do. I worry about therapists for the same reason. I have therapist colleagues who I know really focus on their self-regulation. I see others who don't, and they clearly don't. Yes, they may be trying to save the world by seeing those extra 12 clients in a week, but it's quality as well as quantity. And it also starts with being therapeutically honest and being authentic and saying, am I actually getting through here? Am I giving myself the time even to think about that last session?
Yeah, I completely agree. Especially in a day and age where every hour of therapy is about 40 minutes of admin and form filling and letter writing. So you don't get that reflection moment. I used to actually be a big archer. I used to do a lot of archery. And in archery, as you take a shot, you literally have to have no thought. And you need to be, it's so in charge of your breathing and everything has to be still. And so you can get straight into this mind state very quickly. And it's basically like a wash. And so I use it every time I shift between any meeting or stuff. And it's almost like a complete reset. But you do need to find the time in the day to go back and reflect on each thing you did. You can't just kind of leave it. You have to go and unpack it again. How did I feel about that? How am I going to tackle that? So I think loads of great advice in there. You are running training programs, you're teaching in universities, you're a clinical psychologist yourself, you're thinking about how do you put a system across all of our care services in 11, 12 different countries. What do you do to look after you?
I'm getting better as I'm getting older at making time for myself, but I've always been not the greatest advocate. Studio 3, we have over 50 staff. I don't usually tell people that. And I spend a lot of my time worrying about, are they looking after themselves? Genuinely. For me, there are some basics. Tuning out for my flow activities. It used to be internet chess. It's not anymore because when you're being beaten by 8-year-olds, it's no longer a relaxing exercise. Anything that absorbs me, reading, I'll watch trashy stuff. I do exercise routinely, and I exercise not to do with weight loss. I exercise because of the research on health. I loathe cardiac exercise. For somebody who got to a high level in a martial art, I never actually liked the physical exercise bit. And I think there's a big lie that we give to society that exercise is good and it's wonderful when you get the endorphin highs. No, a lot of people just get pain and they get more pain. That's one of my big ones. I know how to regulate myself or go walk the dog. There are days where I have down days where I will disappear. A few times a year, my colleagues know, no point trying to get hold of Andy. God knows where he's gone. His mental health's not in decline. I just need a day out of that. Some research I've been doing with my colleagues at the University of Northumbria, when we ask people, what are your coping mechanisms for stress? One of the areas that people don't understand is a hobby or an interest or a fascination that you're absorbed in is a stress management strategy. So what I look at is, do people have something like that? In my old days, I'd be able to do my work and then I'd also be able to focus on speaking a bit of Japanese. I love teaching and teaching people something in the evening. It was like a different world I could have. It was part of my stress management tool. It is about switching off, not just switching on, but it's also about how you switch on for work. That's where low arousal comes in. If I'm going to be working with someone or seeing a different patient or client, how do I shut the world out and be totally focused on that for that period of time? So I suppose I do lots of different things and I juggle and I thrive on that, and I do. But at the same time, even I recognise, when do I need to say, whoa, I need to take a bit of time out here.
I have to say, obviously, I've not known you for very long, but it is fascinating that you're a gentleman that's specialised in low arousal, because you are a kind of high energy person, right? So you've had to think academically about how do you step down, whereas there are some other people who have to think about how do they warm up or how do they get ready for things.
This is how I am all the time. When people speak to me sometimes, they read the literature about low arousal approach, and I think they're expecting me to be here with a caftan on.
Let's end with the big one, which is you wake up tomorrow and you've got infinite budget, you're the Prime Minister of the world, you've got a magic wand, whatever you want, and you get to change one thing that you think would radically change the system to help every self better. What would you do?
I did think about this before the call. Unfortunately, I came up with lots of different answers. Okay. It's probably what kept me up late last night for a little bit. It's probably going to sound a bit pejorative, but I'm thinking about my sphere and my work and mental health in general. If there was more money, an unlimited budget, to make us more reflective as a society, that was one. But there's a nuance here. I would shout out for the fact that when we talk about mental health and well-being, there's not enough emphasis given on budget, training, support, counselling, therapies for carers. There are millions of people in this workforce who are unpaid, who are stressed. I would say that I wouldn't put it just into social engineering. I would love to get a lot of our politicians, senior people in finance to understand that they're working very stupidly and wasting an awful lot of money on looking at bad practice everywhere and figuring out how to fix that, rather than saying, where are the best elements of practice in this country in mental health, and what can we copy from them? What are they doing right? So for me, though, basically millions of people around the world who get very little support, and often their children end up sometimes sadly in care. or struggling in society, struggling with work. But actually, if we're going to support those individuals with those mental health issues, we have to do it by supporting the supporters.
Obviously, I don't give people marks, but yours is exactly the same as mine. I frequently say that the whole of society is built on a kind of hidden care economy, right? Which is people looking after their neighbors, their family, their loved ones. And those people obviously don't get any financial support, but they also don't get any psychological support, and they don't get any psychological knowledge either. If anyone's listening from charities or the care sector, I've been spending a lot of time trying to work out how do we give access to transformational, personalized psychological advice to all carers in the world. We could literally change the world one person at a time. It's been an absolute pleasure, Andy. Hopefully we'll get to meet face to face sometime. Thank you for your time, and thank you for coming on Self Matters today.
Thank you very much, Charlie.
Thanks for listening to Self Matters. We've got new episodes out every 2 weeks, so make sure you hit follow and subscribe so you never miss an episode. You can listen to us on Spotify and Apple Podcasts, and of course watch us on YouTube. As always, head over to our social media channels to find out who'll be joining us in the next episode. That's all for today, though. See you next time.